I am Meredith Hirsch.
And I'm Mike Chavez.
And this is Working Healthcare. Physician-owned practices are no longer the norm. Fewer than half of U.S. physicians now work in physician-owned practices, 42% by the latest AMA count. Even orthopedics, once the stronghold of independence, has slipped to 54%. At the bottom is general surgery, where fewer than 1 in 3 surgeons are in physician-owned groups. That decline fuels consolidation, higher prices, and, if you ask today's guest, the slow loss of medicine's soul. Preston Alexander isn't a doctor. He's a revenue cycle rebel, founder of Forward/Health and author of the Healthcare Breakdown newsletter, where he calls himself the Taylor Swift of LinkedIn healthcare writing. His mission is to help physicians take back control of their craft instead of waiting for the system to hand it back. After talking with more than 60 leaders on this show, I keep hearing the same wish. Let doctors be doctors. Preston says that's realistic only if we pull one of 3 levers. Legislation. Pick up the phone and light up your senator's switchboard. Or build parallel paths like direct pay and membership models that bypass middlemen. Or work smarter inside the status quo. Think insurance companies designed by clinicians, not corporations.
And he's adamant that succession planning matters just as much. If junior partners can't buy in, independence dies with the founders. So we'll ask, can the business of medicine fit into already jam-packed medical school curricula? What mechanisms actually fund a junior partner buyout, and what Preston's focused on right now to make physician-owned practices the rule, not the exception?
Mike, those are really big questions for the self-proclaimed pop star of healthcare LinkedIn. So let's dive in. Preston Alexander, welcome to Working Healthcare.
Thank you so much for having me. I am thrilled to be here.
I am so thrilled to have you here. And I want to start with the big question. Besides Taylor Swift, what is killing independent medicine?
I think that what's really killing it is the financial mechanisms built into the foundation of the healthcare system and piling on top of that quote unquote solutions that are supposed to make it better, but really just adding to rising overhead costs, administrative burden, and general increasing cost to just try to keep up with meeting the regulatory requirements and even just earning a normal living in private practice by battling with the insurance companies, which only exist based on those financial foundations and model of the current system. So we definitely have a big hill to climb. And I think there are certainly ways, like you mentioned, those sort of 3 levers, but it's a hill for sure.
So which lever do you think is the best lever, or do you have to hit all 3, or can you pick 2 of the 3? Like, what's the secret sauce?
Yeah, I mean, I think it's all 3. Like it just has to be, but it's nearly impossible probably to focus for any one person or group, to be everywhere all at once. Meredith, I know you do work probably in all 3 camps for sure. But we're not all superheroes after all. But it's important because again, we're talking about a system level change. We're talking about the healthcare system, which is based on rules, regulations, laws. CMS is a government entity, and those things have to change. So yeah, we have to pull on legislation, but it's the slowest. And if we just wait for senators and Congress people, and especially, apolitical, but it doesn't look like it's getting any better. I'll just say that. We need to pull on those other 2 much harder. And we need more mechanisms, companies and leaders and founders and everybody in between to pull on those, which is to work smarter within the current system and put the things in place. Because listen, independence is hard, but we see thriving independent practices all over the place. It's not like it's impossible. And one of my favorite quotes is, don't think it impossible because it's hard. If someone else can do it, it's possible and you could too.
Are we overregulated?
Yeah, I think so. I think we are for sure overregulated.
You had to think about that. I would have been like, oh, yes, immediately. But why did you hesitate on that?
Because to me, like, I get in these conversations a lot about like the free market mechanisms in healthcare, and it's America's capitalist society, and whatever you want about or your philosophical, political, economic, points of view. But to me, I think true free market capitalism in healthcare is hard and doesn't really make any sense. And that's just my personal perspective on it. So I think you need a degree of regulation in probably, and I might think even a higher degree than probably some other people think. So I paused about it because I think we've stacked a bunch of regulations to try to fix really bad other regulations. So perhaps I could have been like, oh yeah, for sure. But I definitely want to just nuance it by saying like, there's a degree and maybe even a sizable degree of regulation required, or else in our broad financial system, I mean, imagine if you took all the regulation out of health, I think it would go insane and we'd be in a way worse position than we were in today. If we just totally said, caps off, free market, capitalism, go, it'd be dire.
Right. You started in revenue cycle ops, not med school. What was the aha moment that turned you into a champion for physician independence?
So actually, I didn't, my business partner started in revenue cycle. I actually started in medical devices. So I accidentally tripped into medical device after I got an MBA into product management at a global device company. But I absolutely loved it. I thought it was fascinating. But over the years, kind of two things came up. One, there was this sort of looked like this friction dissonance between like what people talked about, what we talked about internally in the company. How do we increase our margin? How do we make more money? How do we ship more units? How do we da-da-da-da-da? We have this amazing healthcare system. But then on the flip side of just like real life, I wasn't seeing it. And I was reading about it and hearing. And then eventually I realized I knew like nothing at all. Like we sold like supplies into like one small unit of the hospital. And so I wanted to learn more because I just was fascinated with healthcare and it was so complicated. And I had this moment where I was like, I have no idea, like, what am I even a part of? And so I started writing about healthcare, knowing that I didn't really know what I was talking about, but looking for people to give me sort of feedback. Because, on the internet, if you say anything, you got a lot of people who are going to tell you you're wrong. But I was counting on that. And so just from honestly years of writing about healthcare, learning and connecting with people, I just sort of flippantly one day as I was, I don't even know what I was thinking about, but I wrote that the business of healthcare is destroying the practice of medicine. And I was like, oh, I'm like, dang, yeah, we need to fix that, right? And it was like, what do I as a patient experience? Like what's central to my care? Like what do I appreciate the most about anything? And really all that matters to me is like that I have a clinician taking care of me. Like that is healthcare. We need that back. And so from there, I went on a rebellious Taylor Swift fueled mission.
Exactly. And instead of bad mouthing exes, right? You bad mouth the insurance companies. So exactly. You're billed as the Taylor Swift of LinkedIn healthcare. How has that pop culture persona opened doors for you or slammed them? I really want to know regarding your advocacy efforts and talk about how important connections are, because that's actually how you and I met. I met Mark Craig, who introduced you and I. I joke that Mark Craig only introduces me to people who have two first names, like Preston Alexander, or Wendy Dean, or Matthew Zachary. I'm like, yes, only two names and two first names. But how important are connections in your advocacy journey?
I think they're super important. And then it's interesting though, because when I first started off, of course I was like very buttoned up and very, whatever. And then it was really when I started writing the healthcare breakdown, I write very just like free form. Like Meredith, if you proofread a single thing that I wrote, you would like go insane and be like, I can't read whatever.
I know. He's like I don't write things grammatically correct, Meredith, and I just write in stream of consciousness. So don't edit my work.
Right. Never edit. Yeah. My mom gets on me a lot. She was an attorney. So she's like, this is awful. And I'm like, well, but so I kind of thought I wasn't really going to be, I did not think I was going to be taken seriously, but I was like, this is only going to like resonate with like a very small portion of people, just because of like the style and sort of how I wanted to be a little bit just iconoclastic, like, right? Like Taylor Swift and healthcare, like who takes that seriously? We're all like, you know, old school in the hospital, wearing suit and tie, whatever. Like I wear a t-shirt and jeans. I talk about Taylor Swift and like use bright, like loud colors. But the substance was there enough that it resonated with people. And I think people appreciated just like a non-polished sort of voice in an otherwise like very like, rigid, structured PR, vanilla landscape of healthcare. And so, yeah, I think I've had some people be like, no way, I don't take this guy seriously at all. But like, probably the type of people who like, if we actually sat down for a conversation, we'd pretty quickly be like, this isn't gonna work. So it's really just been a good filter to connect with people more authentically and genuinely. But I've connected with amazing people who go do work in Washington, who lead health systems, who are, formerly in like leadership in payer organizations and everywhere in between. And so I really just think that substance, if you can hit that, then like the delivery mechanism, as long as it's not too crazy, has been fine.
Yeah, you definitely need to, within the social media realm, set yourself apart. The AMA surveys put physician-owned practice at just about 42%. What stories are you hearing about physicians and the difficulty in owning their own practice? And you talk a little bit about succession planning as well. How do you see that fit into the whole picture?
Yeah, so I think it's like, to answer it in two parts. The first one, which is one of the hardest ones, is just contract rates. And I mean, I think there's a broad common misconception in the public that like, doctors are overpaid. And then they talk about like, they're really talking about salary. They're not really talking about reimbursement. And then they think, well, reimbursement is really high. And I'm like, first of all, $1,400 for like a full knee replacement, like doesn't seem like a really great value trade. Plus that's $1,400 in like revenue to pay for all of your business expenses. Mm-hmm. That's not like you, like somebody hands you a wad of cash and then you like, go home for the day. It's like there's a big misunderstanding there. So anyways, but so we look at these contract rates and like new practices open and then they go get in network with like United or Cigna or Aetna or whatever. And they basically are just like, yeah, thank you for 85% of Medicare. And that's it. Like they're not going to negotiate with you. They don't care. You have no leverage. You have no power in that table. I mean, yeah, you can go join a CIN or an IPA, which can be a great mechanism, but that is also going to necessarily preclude a lot of people from even starting at first. And then on the back end of it too, I've talked to docs and they just get a letter in the mail from, whomever, whichever plan and say, guess what? Here's your notice, 60-day, your reimbursement goes down 30%. And you can't
operate. Or you're kicked off, right? Or you're kicked off the health plan entirely.
Right, that's it.
Yeah.
There's like no negotiation, no nothing, plain white envelope, like 5 sentences. And it's wild. And so can you fight back against those things? Like, yeah, sure. But like, if you're a 2-doctor group and like, how much leverage do you have? How much time do you have? Where do you even start? Like, who do you call, right? There's so many like little things that really add up to put those pressures. And that's why I talk off the bat about financial structure and underpinning the whole system and the design of it, because we're talking about, the revenue of a business and you just get to turn it on and off when you're already doing the work and service. It's a huge problem just to start, let alone to thrive, let alone to survive in a lot of cases. And then from the succession planning, it's kind of similar in a way. I mean, like long term, it's hard to know where you're going to be. But at the same time, it's like if you've spent all of these years and you've built a good practice and you're well respected and it's been hard and you're in your 60s or 70s and any other business anywhere else, you're going to be like, all right, it's time to retire, right? It's time to exit. Like, how do I exit this business? You don't just like put a close sign on the door one day. You can sell it. And then you have groups, private equity health systems coming in and offering you these high multiples on your EBITDA. Like, it's hard to say no to that because you put so much work in and you don't know what the future holds, and it's gotten harder, and you're like, yeah, 7x sounds pretty good. And then to the docs behind you, but if it's a 3 practice group, like probably not. But even if you build a big one, do they have the wherewithal, the desire, or the capital, because they're still paying their student loans, to pay you 7x on the practice multiple? So yeah, both of those mechanisms, I mean, they create a lot of difficulty in getting us in a place for long-term independence and for succession.
There's a big group in Florida right now that's very much working to end the corporatization of medical practices. And I am always looking at things from the devil's, perspective and try to combat it. And my question always goes back to pretty much what you said, Preston, is we've worked so hard. We've built this practice that's worth X amount, because it's not just me. We have, I'll use my group for an example. We have 8 providers. We employ 60 people, and we have one owner. And it's my husband, and he's 55 years old right now. And he's looking at saying, okay, what is the succession plan? We both believe very strongly in independent medicine. Where are we taking it? And there aren't a lot of options. And you're like, I don't want to sell it to the devil. And maybe I need to. Maybe do I just walk away? Does anybody really care? Does anybody even want to take on this ownership? So ophthalmology, shockingly, I was researching this, 70% of ophthalmologists remain independent. How do you think they do it? What's their secret sauce?
That's it. I didn't know what that statistic was, but interestingly, we're seeing there's a ton of private equity involvement in ophthalmology right now. And so I wonder, sometimes I look at independent numbers and I wonder, because, sometimes it's hard to know what's truly an independent practice, and are they backed by a private equity group? And then they're part of an MSO, and you're like, well, who owns the MSO? And it ends up being private equity. So there's a lot of private equity in ophthalmology. But interestingly, I was actually a year ago or so talking to an ophthalmologist, and he and a bunch of others left a private equity group because they were like running it into the ground. And he told me that he knows his numbers really well. His break even on a day is 3 patients. He only needs these 3 patients a day to break even. And, there's some capital intensiveness in ophthalmology, but, there's also the reimbursement is there. Plus, there's a lot of ancillary and other things that like you can sell and do in ophthalmology. It's why dermatology has remained so strong, because it sort of is a natural lending to it. But also there's a lot of rigor in keeping overhead really low for him and for I think a lot of these independent, and just based on some of the cash pay mechanisms and like how those ophthalmology practices are set up, I think that it just a little bit, I'm not saying it's easy. Again, it takes discipline, and he does a lot of work, and he's really smart and, like everybody, and really hardworking. But it also is a bit of the specialty that lends itself well, but it's also why private equity is super interested in it.
Right.
There's good reimbursement there.
You're totally right. My dad's a doctor, and my dad left medicine when he was young, in his young 40s. And my brother always wanted to go to medical school. And my dad said, you got to do something cash-based. Dermatology, plastic surgery, pick it, Brian. You got to pick something. And my brother's a dermatologist. And so he remains independent, and his goal is to stay independent. But it's much easier because he has all of these cash procedures. He does Mohs surgery. I look at our practice, and we're 80% Medicare. And why we're able to stay independent is honestly because I'm scrappy. I'm finding a new ancillary to bring on every year, and I'm playing the game of dodgeball because Medicare is consistently trying to cut reimbursement in different areas, and I'm involved in advocacy to fight to make sure that we remain receiving the complex code for different infusibles as opposed to some simple code. You're not reimbursing me like a flu shot when I'm giving a complex biologic or a monoclonal antibody. And so it really takes people to get involved. But gosh, 60% of my revenue is medication. And so we're looking at that from the side as well, right? The cuts, the more government regulation, let's, standardize what the spread is on medication reimbursement. And then you're like, man, if you take that away, I can't have an infusion clinic. And then you send patients over to the hospital or a standalone infusion center, or my favorite, United Healthcare loves to send LPNs to people's homes and give them Remicade. And you're like, are you kidding me? You don't even have a doctor overseeing this. And so you're putting patients at risk. And so it just, like you said, you dig a little and you dig a little and you're like, oh my God, this is an avalanche. You're unique. You wanted to learn more. It's because you're smart. That's the truth. You wanted to learn more. How do we get other people to want to learn more so that we can create change?
Wow. I don't know. That's a hard question. I think that, how do you get people to want to learn more?
I don't want to give up.
Like you show them the possibility on like the other side of where they are now. And I mean, I think if we talk in the context, two sides, I don't know, two contexts. One, which I talk to folks about all the time, is like just the average person, right? Like I'm like such a bummer at like a party because like I just want to talk about healthcare and like I sound like I need to like go grab like some tinfoil out of the kitchen like, and put a hat on sometimes when I'm there. But it's important because, people are starting to feel it, sense it. They're starting more and more experiences with the brokenness of the healthcare system, or not really the brokenness, but the poor design of the healthcare system. Yeah. But there's still like, again, like big misunderstandings. But as they start to see it, they do want to learn and understand more, kind of like what's going on? Why is it like this? And so just showing them like a little glimpse of like, it could be better if you kind of knew what was behind the curtain a little bit. You should learn about this. And I think it goes the same way with either physicians or any clinician, right? Like I try to always caveat physician with like, and other clinicians, because inevitably like a pharmacist comes for me or like a respiratory therapist. But like any clinicians to say like, this is really important because what's on the backside of this is the future of medicine and how medicine is practiced, because it's leading to consolidation. Like more hospitals are getting bought, consolidating, buying practices. Like you're going to go work for Tenet or HCA or Ascension or Advent, these big, massive systems doing billions and billions of dollars in revenue and cash. Or it's Optum who's employing 100,000 doctors now. Like they're the largest employer of physicians. Like, and these companies are designed, they actually can be sued if they don't act in the interest of their shareholders to produce as much profit as possible. So I think the curtain's starting to come down, and I think the more we can do to be like, look at how this directly impacts you. And if you knew about it and understood it, and not in a, condescending way, but just like, you could really overcome this, help people more, help yourself. So I think it's really just exposing what people have been reluctant to learn in the first place. And then they go, oh, what? I didn't know that. Wait, explain that to me, and they start to get a little more interested.
Yeah, I think it's becoming more and more critical to the need for them to understand is going to come out of necessity inevitably. And I'd like to hear your opinion on this, but I think it goes back to what we talked about in the intro, and there's nothing or little to nothing in med school taught about the business of medicine. And again, I'd like to hear your opinion on that, Preston. We did a talk, I partnered with a rheumatologist in Long Island 3 years ago at NICA in New Orleans, and the topic was the business of medicine from a doctor's perspective, and we run an MSO company. In our perspective, the business people. We had 45 seats. It filled up in probably 15 minutes. And there were people like texting me trying to get into this class or this talk because so many people wanted it. So I think maybe the need's there because they're starting to understand we need to understand this stuff, and we weren't taught it in med school. So again, I'd like to hear, is that what you're experiencing?
Yeah, no, 100%. And I think, it's interesting. So when Maren and I were talking, and I was like, yeah, they don't teach this stuff in med school. And it was a great point about like, yeah, but also Shouldn't doctors be learning, like, there's only so much time to learn all you need to learn about medicine? And I was like, okay, that's really fair.
That's
But
what I
certainly,
was saying, because we talk about the 10,000 hour rule, right?
Yeah, right.
You know, you're in med school for 4 years. Where are you fitting this into the curriculum? So yeah, where are we fitting it in, Preston?
Yeah, I have no idea. That's a great question. Maybe I'll ask some people in higher education. They would know better than me. But I will say, and interestingly, so I wrote a while ago when I was first getting a bit of a voice on social media, a post or an article kind of to the effect of or I think doctors should be able to just be doctors, right? And like not worry about business, because like I want my surgeon to think of nothing else if they're going to be cutting me open and rooting around and sewing things like I don't want them to think about anything but that, right? Because it's like a high stakes situation. And I got something really interesting and it made me think a lot about it. And it thought more about like the idealism of it. And it's like, sure, ideally, right? But then at some point it was just like, however, our system, again, is if that happens, which it obviously has been part of the cause of all of this, is that they said, oh man, I just want to do this. Someone else take over, someone else do it, someone in the business, I just want to focus on like the one thing. And then so now we're seeing it, on the backside of it, which is I've never learned any of this stuff. Oh, I had no idea. Now they're hungry to learn. More clinicians, physicians, physician owners, everybody are hungry to learn this stuff because they realize like, oh crap, I've been getting hosed for 20 years. And now like looking around like, what happened? And then, because there's been a very intentional, like, if you're a hospital and you are an academic medical center and you take residents and, whatever, it's like, I don't want you to learn about business. Think of that pipeline. I now can control your contract better. I can talk about RVUs and you have no idea what I'm talking about. I can put non-competes in places. I'm dangling a big salary because you have $400,000 in debt. And like, I don't want you to go out there and set up shop across the street. And you mentioned rheumatology, like the biggest lie rheumatologists are told in the hospital is that they lose money for the system. It's like, well, yeah, if you just built E&M codes for like a rheumatologist and then you pay them a high salary because they know all the money they make is on the back end and all the infusions that they prescribe. But without the rheumatologist, no one's getting an infusion.
Exactly.
And so we see this, and like I know rheumatologists who've wholesale left health systems after being told this for decades, and they went out on their own and they crushed it, and then the rheumatology and infusion center closed the hospital. So like there's a very intentional like, don't learn about business. Don't worry about that. You don't need to know. Just do medicine. Like, let us handle it. We got it, right? And now people are like realizing like, oh my God, they're burning out. The health system's rough. Optum's buying things. They're like, we need to know. We need to look behind the curtain because we've been forced to. And now we need to take things back.
I'm seeing not a lot of people in my generation, a lot in the younger millennial generation getting involved, and a lot of the baby boomers who are involved. And Mike and I were at the Florida Medical Association conference a couple of weeks ago, and one doctor in particular told me, as I said, we need more people. It's always the same people. It's always the same number. It's always the same people who keep showing up. And there are some revolving doors at the younger age, but it's always like, your age, I said to her, because she's a baby boomer. And she said, when I was younger, I had no desire to learn any of this. And just like you said, 20 years in, she's like, I knew I had to learn. And the more I realized how the pieces fit together and how it impacted me and my livelihood and my health care as well, I knew I had to get involved. And so I'm starting to see this with my new physicians coming on board. They come in and they don't even know how to code. And I'll say, you need to code yourself. We're not coding for you. And they look at me like I'm, some alien. And I said, you're the only one who knows what you're doing with this patient. You have to understand what a level 3, a level 4, a level 5 office visit is. We have an independent auditor who comes in. My team may question you on whether or not it is that level, but you need to understand how to code. And then I tell our mid-levels, you have to understand incident to billing better than anybody, because you're either billing under yourself or you're going to bill incident to. You need to know when to send it back to the doctor or when you can take care of the patient. But it really is that ownership, right? People who are in medicine need that ownership. How do we stop the bleed of our brightest and best going to Wall Street and then working for these VC and PE companies and then trading the money on Wall Street?
I mean, they'll eventually come back around and buy the practices, though, right?
That's what I'm saying. That's what I'm saying.
If there's any practices left.
I know.
Yeah, right,
I mean, how do we change that? What do we do with the system to change that?
Oh, man, the $1 million question. I mean, I think it, honestly goes back to those 3 levers. Like, I don't know or see any other options that we have, because you're super smart. You can go be a doctor, or you can go, work on Wall Street or whatever. Or, these days people want to be like a YouTuber or TikToker or whatever. But like, just look at the numbers. I mean, like, medicine remains a noble calling. It was a noble calling before, but it's a noble calling that you could just like go answer the call and you'd make enough money. You'd survive, you'd be independent, you'd be in control. Like, and I don't mean like in control in some kind of like, I just want to control everything, like in control of the care that you provide the patient, like in control of the decision making along with that person and with the human connection, which is so important. And now that's the control that has been lost by and large. But yeah, if you just look at the numbers, like, okay, I could go answer the noble call, but like, if I just look at my hourly rate for that, that's pretty rough. Like, no one's in it like just for the money, but like, you should be able to make a living, especially for the value that you're trading, which we have totally upside down in healthcare delivery. Like, and then you look at reimbursement. I read an article. If you look at like a heart transplant doc CPT code reimburses like $4,500. Like, what? Like, that's it for like taking a heart out and putting a new one in? Like, it makes no sense at all.
Well,
Wow.
Yeah, no, it's crazy. I'm in a situation now where we brought on an internist, and I thought that I had group contracts that covered any specialty as a group contract. Every insurance company other than Florida Blue, well, I'm not insured with that many insurance companies because the rates are so deplorable, but specifically Florida Blue said, no, I'm not giving you the same rates I give specialty in rheumatology. I said I had sports medicine. They're like, no, that's specialty. We're going to reimburse internal medicine differently. So we're waiting for the rates. I'm telling you, they want to give me $70 for a level 4 E&M code, level 4 office visit to see a patient. And this doctor is spending 30 minutes easily with the patient. We do a lot of coordination of care. I have patients, there's concierge medicine is huge in our area, and I have these Florida Blue and Blue Cross Blue Shield patients willing to pay out of pocket, and I'm not taking $70 for it. My overhead's more than that. Yeah. And they're adamant, and they want us to sign. And I really think it's a network adequacy issue that they're offering. Who's going to take it? I'm going to give you 70% of Medicare. Who's going to take it? I can't take it. Are you even going to get the best doctors?
Yeah, that's insane. Some of the rates you see, it's preposterous. And so, it's hard to say like, yeah, I could go be a doctor, or I could go, work any number of other things and sectors and jobs and get done at 6 o'clock and be done for the day and make $200K. And like, that's great. And no debt and no this and no that. So I think until we can create a better system, improve this system, show better pathways, because I think the ownership piece, I heard a doc talk recently, and we were, people talk, and I say it all the time, like, we should do this should be that way, it should be this way. We were talking about reimbursement, and he was like, y'all quit talking about reimbursement, go open an ambulatory surgery center and get the facility fees. Like, we don't need to be talking about like your physician fee schedule anymore. Go participate where the money has been going in healthcare. And I think that's right in a lot of ways and true. because you have to look around and like why rheumatologists, need to go and open an infusion center and why orthopedic surgeons need to own ASCs and vascular surgeons or multi-specialty groups. Why advocacy is important though, because we need the moratorium on physician-owned hospitals, which is ridiculous, to be lifted because like we're looking at Medicare and we're looking at like blue plans with the audacity to say $70 for like if you just do the math on that, even if you gave the doctor all of that money, which isn't how it works, again, that's just like they could go get an hourly job somewhere else without the stress or the training or anything to be a doctor. And so it's pretty preposterous. I think it's going to be hard, but we're seeing the effects. We have a physician shortage. Part of it's allocation of resources, but a big part of it's less and less people go, unfilled residency slots. And then the people who go, who wants to go say like, yeah, I'm going to go do pediatric internal medicine, which has the worst reimbursement, the lowest salaries, the whatever. People are going to be like, I mean, I want to do that, but at the same time, like, I'm coming out of medical school with how much in debt? I want to one day retire. Like, I want the hours. They're not going to choose that specialty. And they're going to be unfilled slots left, right, and center. And that's what we're seeing. So, It's, like I said, uphill climb, not insurmountable. I don't want to be the doom and gloom guy with my tinfoil hat on. But there's hard headwinds.
So when we talk about the three levers, or you talk about legislation, the direct pay models, and then fixing the status quo. Which of the levers do you think is actually moving right now?
I think the biggest moving lever right now is direct pay. So tons of primary care doctors are going with direct primary care models. I would say if you wanted to call it a specialty, it's probably the fastest growing specialty there is. Now, growth on a number of 0 is going to always be high growth, but still, if you looked at like DPC Frontier and just saw the number of DPC practices around, the number is staggering. So, and the reason I bring that up is because like within that direct pay, DPC, whatever, I also think a lot about self-funded health plans, because on the flip side of that is like, okay, we talk about reimbursement, what's this plan paying, yada, yada, yada. But these payers are really just claims processors. They're just taking employer dollars and then spending them however they feel like, and then charging the plan way too much money for something that they're not actually paying for. They're just processing and adjudicating and whatever. But then, so there's this huge opportunity for a self-funded plan to say, hang on a second, I'm paying, how much of this, and you're making how much, and you're spending this much on the specialty pharmacy and the PBM that you own, and then you redirect all through, and you're like, there's so much money being funneled into all of these intermediaries. So when you do a direct pay model, and we talk about it, we're like, okay, physician, patient, great, okay, 1-to-1, right? But in a self-funded way, you're still creating kind of a network, but it's still a 1-to-1, because then basically the self-funded plan is in a way employing the physician, and there's no middleman, because there's no, there might be a TPA, right? But like a good TPA is going to do and act in a way that's responsible for the health plan as a fiduciary of the plan, and they're going to lower the cost, because like we see these self-funded plans save millions and millions of dollars for employers, like some on an annual basis, but certainly within 5 years or so. And people are getting faster care, they're getting better care, it's higher quality, people are happier, they're spending less, because it can be a lot of the times a $0 health plan with no deductible, so long as you go in sort of the network that they've built. But you're just taking out all the junk.
Yeah, but you are taking out all the junk, but you have to be pretty large to do a self-funded plan. And that's what gets a little scary.
Yes, yes and no.
Okay.
Because I know, and they should be on the podcast, because I know a ton of self-funded guys, and sure, a sweet spot, maybe. But we're not talking Home Depot. We're talking like 50 to 100 employees who can self-fund, because like that's the amount of savings when you just say like, I'm not just going to like ask United to do this, because like if you were running a practice, like think of your practice, if you could just run it on cash and didn't have to have all the billers, and your clinicians weren't coding anything, they were just seeing the patients that came in, their time, all these things, like what you would actually need to charge to still make money for that, you could probably charge like a very, very reasonable rate, or which, you do it in DPC, it's membership based. And so as these patients are coming directly from employers, even if it's 50 or 100 or whatever, the rates are low enough that you don't have to have this massive scale to self-fund, because and then you can have more control over the steerage, which surgery centers are you going to be using, like which hospital can you potentially go direct contract and bundle certain services with that are like the high claimant like costs, how much are, or most frequently coming up. So I will push back a little bit on that. There is a little misconception. You don't have to be a massive Fortune 500 to self-fund.
I don't think you need to be a massive Fortune 500, but I look at our team of 60 employees, and some of the younger patients, they would be younger patients, but my younger team members who have no issues at all, they're going to be free for me, or low costing, but it's really economies of scale. And if I get 1, 2, 3 disease states and I'm paying for that, that can get very expensive. And I know there's insurance to back us if we are self-funded. But I actually did the research on the direct primary care clinics. There are 2,600 that now operate in the U.S., which is staggering.
Yeah.
What do you think, though, the biggest myth about going cash-based is? Because there is a myth to it.
Yeah, that it's more expensive and that your health care is already paid for, right? Insurance pays for it, that someone else pays. But both of those things are untrue. And if you can just do a quick back. I did this with my parents and they're on Medicare, and I was like, they were easy because they were using like a concierge doc, and I was just like, how much do you pay? And it came out to be like, I don't know what it was, a few $100 a month. And I was like, that's a direct primary care membership. Plus, you're not using your insurance. So like you don't have and then if you can get meds, and most direct primary cares can just dispense meds directly and they just pass on their cost, it's like 1 cent a pill, 2 cents, it's nothing. And their labs are generally at cost. So it's $30 a lab as opposed to like having to go pay 50 because your copay. So I think like if you line item by line item and you take your copays into account, your premiums into account, like your co-insurance, all those things, actually did the math, it's less expensive.
And it could be, but I always think of catastrophic care. What happens if you end up in the hospital? What happens if you end up with a horrible diagnosis? What do you do?
Yeah, I mean, I think that there's 2 things. One, you can still carry like a traditional insurance plan with a high deductible. You get the lowest premium possible, and then you know that your deductible or your max out of pocket is going to be high. But again, this is for catastrophic. If you can float it, right? For my family, like we do the math every year. Like we use traditional insurance as much as I like direct care models, as much as I like self-funding and all those different mechanisms, because we do the math, and we have some health conditions, and it just makes sense from a math standpoint because we're in the top tier of health spending. But then there are new types of insurance models, pools coming up that can work. There are these share ministries and share like pooling, risk pooling, that basically is in a way kind of like a traditional, but there's no muck. Like you only use it for like the high dollar amount, like catastrophic things, which are much higher than I think most people know, right? Oh, I need an MRI. My doctor said I need an MRI. And it's like, you think it's going to be $8,000. It's like, no, there's cash pays places where you can go get an MRI for $300.
Mm-hmm.
Like, that's not bad. And, again, and caveat all this, where like there's plenty of people out there. That's why I also don't think it's a silver bullet, because there's plenty of people who can afford $300 and they cannot afford $99 a month memberships. Like it's just not in the calculus. So, but it's also why I kind of like self-funding, because and just the model in general just shows what's possible from a cost savings perspective.
But
what's
you're a business person.
Cost spend.
I mean, Preston, you're a business person, and I follow you. Mike follows you. It totally makes sense. But I think for the average American, they don't know how to figure this out. It's so outside their realm. I think there's a huge opportunity right now, though, for independent practices to have somebody like you, even though I know you don't run practices, but somebody with your knowledge, somebody with Mike, somebody with mine, to steer and to partner with physicians. And I also read I'm all about statistics, but 4 in 10 doctors are eyeing a change. We have burnout. We have you said 60 or 70. I'm like, I know a ton of doctors in their 40s who are done. But they're eyeing a change in the next 2 years. How can independent practices turn that movement into strategic recruiting? How can we get these physicians to say, to heck with working at a United Healthcare hospital or working for this huge managed service organization or XYZ? What can independent practices do?
Yeah, I think that, again, to the education question, earlier, Mike, is showing them the possibility and what the different way is. And I think of social media a lot. So, there's a huge, I actually don't have the TikToks or the Instagrams, but I do have LinkedIn, obviously.
Well, I was kicked off TikTok, so I don't have TikTok anymore either.
Oh,
I've got it. I love it.
He loves it. He sends me stuff, and I'm like, Mike, I don't have TikTok. He's like, get TikTok. I'm like, I was kicked off. They didn't want me. I told the truth.
You were banned. TikTok banned.
I know. I wear that as a badge of honor, to be honest.
I think you should. I think it's great. Yeah. I got banned once from LinkedIn, but it's because I had too many tabs open. It was a weird thing.
And you have 35,000 followers. How do you get that many?
I don't know. The answer is I have no idea.
I want to be like Preston.
A clever headline, I think, is the way.
That's what it is. I need Preston to use his stream of conscious writing for me. So what can independent practices do?
Yeah. So I think that, honestly, social media is a great way to do it. And I think mentorship is a great way to do it. I think of it from a marketing standpoint, because you can market for new patients, right? And we talk about it all the time, right? How do we get patients in the door? Referrals. But sales and marketing, same skill set to recruit. You're trying to show people where they want to come be. Mm-hmm. You're trying to show a doctor, where is it awesome, right? Come use my service, which is my employment for you, or my partnership if you want to be a partner in a practice or something like that. So same kind of mechanisms. And I think it's really easy for physicians and, all clinicians to, very traditional, again, here are my credentials. I'm 7 septuple board certified, and I'm, this and that. And you're like, okay, I could go work here. I could go, but that all kind of looks the same. But when you step out and you share on LinkedIn, or you're on, you probably follow Lady Spine Doc, she's in Georgia up here. And I bet that there's plenty of docs who are like, man, if she had a practice, she'd get hit up all the time, right? Mentorship opportunities. People who want to go work for her, work with her, be in that realm. Because if you just step out, show your personality, show how great it is when you're independent, when you run the show, what it's like, the business side, how exciting it can be, holding an insurer's feet to the fire on contract negotiation, because what feels better than that? Then people are going to be like, that seems cool. I kind of want to do that, or learn, how did he do that? If he can do it, or how did she do that? Maybe she'll teach me, I think you attract people, and I think you think of it as a marketing exercise.
I actually love that, and you put it really well into words, because I've always tried to hire rheumatologists, and I have actually 5 interested in a position right now in my practice. I have rheumatologists listening, who are probably very jealous. It's very exciting for me, because they have found us. They see Mark and me as a partnership, and they see him doing all of this work and advocacy work and leadership. They see what I'm doing, and they're like, oh yeah, they seem to know what they're doing. I'm not going to lose money with them. I'll actually, I think, do okay. Maybe I'll learn something. And I love, you actually put it very well into words. And I think that physicians need to step outside, and you're of a younger generation. I don't even know how old you are, but you're younger than me. And looking at doctors who say, oh, I'm not on social media. I can't have my patients reach out to me. I can't do that. And my husband's on LinkedIn, thank God. Like, I think in the last year I had to teach him how to use it. He's like, oh, Instagram. He like looks at it like he's freaking out. He was excited something went viral for him. Yay. I still haven't had that happen. I'm like, what is going on? So he is embracing it because he's realizing that is the platform to get the message out.
Yeah, absolutely. I mean, it's a megaphone for like all of the great things. And
Yeah.
people like poo-poo social media. And like, yeah, you can like doom scroll it all day. But you can also really use it as this conversation, 0% chance it'd be happening if LinkedIn wasn't a thing. Like, it just wouldn't. So you just think about the reach and what you can really do, who you can attract. And like, that's what we need. Because like, as much as the employment curve is doing this, the sentiment curve is doing that. And so like, people whose sentiment is doing that are looking for something to latch onto. Just be the thing that they latch onto.
Yeah.
If you had 5 minutes with every med school dean, what's the one message you'd deliver?
Let's teach them.
Did you put me on blast? Is this the last question?
No, it isn't. It's always if you could create
even?
one change.
Close.
But I love that question because I love it because it wraps it all together. You're not going to give them an MBA and an MD or a DO. So what are you going to have every med school? What are you telling every med school dean?
I mean, I think that I would talk to them about the current state fact of healthcare is that it is inextricably linked to financial and business mechanisms. And if we don't start teaching the future generations of physicians and all clinicians about those mechanisms and how they are going to impact directly practice, no one's coming to med school eventually.
I know. I think of my youngest son. He's still trying to hold on to this minor in neuroscience because he's like, maybe. But this summer, no. What did he do? He did a finance internship.
Yeah.
Where are the brightest and best going? And that's what you have to figure out. So now here I'm going to ask you my final question.
Oh, no.
Preston Scott, Preston Alexander.
I should have known. I know I have 3 first names.
I know.
That's a good thing or a bad thing.
Preston Alexander. If you could create one change within our American healthcare system, what would it be?
I'm going to go specific because this like came up recently. If I could create one change, like magic wand wave, I would create a way to hold all insurance companies liable for the medical decision making that they are involved in when providing reimbursement, denying care, and causing prior authorization delays for patients to get care that they need.
I really love that, and I'm not ending because I want to share this with our listeners. And I love what you just said. You're right. Accountability is so important. You and I had a conversation, and you made me think about it differently, and I wanted to share. My son just had his tonsils and adenoids out, and he has sleep apnea from his tonsils so large that when he sleeps on his back, his tonsils actually constrict his airway. So the insurance company is covering 100%, no deductible, not a dollar do I need to pay. They're covering anesthesia, they're covering the surgeon, they're covering pre-op, post-op, follow-up, everything, all the meds, everything. I needed to do more genetic testing. And family history, my personal history. Last time I did this testing was 15 years ago. It was time to get updated. My OBGYN was like, you need to do this testing. It was only $100 and it was denied. And you said, I was like, why'd that happen, Preston? And you told me why. Share that.
Because if they find something in that genetic testing that you then go and get treatment for, they have to pay for it. And so they would prefer to deny the cheaper thing on the front end to either, in some cases, theoretically prevent, but that could cause them any kind of hardship on the back end financially, they will likely deny it.
And why'd they pay for every penny of my son's surgery?
so that they didn't have to keep paying for the ongoing care and treatment.
Yeah.
Wow.
It's all a financial decision. And again, like these financial decisions, which is why that's sort of my magic wand wave, because like I think everything else is pretty well covered. I think we know all the wands we can wave and what they could do, but I don't think people talk about that enough. Is that like these insurance companies are de facto involved in medical care and decision making, and they should not be, and they are absolutely not held liable for how that is impacting patients, leading to, you know, more severe things like, you know, and I know I don't mean to pontificate, you can cut this part out, but you know, I know I'm going a little long. You know, we see that a lot because I'm involved in some like wound care practices and clinics with like in vascular with limb salvage and revascularization, because an insurance company would prefer to cover an amputation versus a revascularization for limb salvage, because that patient who gets an amputation will die sooner and they won't have to pay for care.
Yep. You're right. You're right. And it's morbid. And that's why we need to go through the insurance companies. It's why I was banned on TikTok. It's why you are the Taylor Swift of healthcare writing on LinkedIn.
Yeah.
You taught me something, and I want to just thank you so much for your candor.
Oh, well, I appreciate you, you know, being interested in it, having me here, you know, sharing another platform and making Mike a Taylor Swift fan after all.
Exactly. And if anybody wants to be not a Swiftie, but a Presty, they can go follow you on LinkedIn, where you definitely own the platform. So thank you, Preston Alexander.
Thank you so much, Meredith and Mike. It was a real pleasure.
To everyone listening, the full video of this episode is now live on YouTube. Just search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind-the-scenes moments. And if you've got a question, an episode idea, or someone you think that we should feature, of course, you can go on LinkedIn, but you can also email me at meredithhirsch.com.
And if this conversation hit home for you or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post it on social. You can follow us at Working Healthcare on Instagram, Facebook, and YouTube. Meredith and I are also individually available on LinkedIn. That's where we keep the conversation going between episodes. The more voices we bring into this space, the more momentum we build. Because change doesn't start with a policy. It starts with a conversation, a real one like this.
New episodes drop every Tuesday. Subscribe and don't miss what's next, because you can't fix U.S. healthcare until you understand how it works. I'm Meredith Hirsch.
And I'm Mike Chavez.
Tune in weekly as we explore the inner workings of healthcare.